Okay, well, I hope you can hear me today. Yesterday, the teaching session we had didn't work. I think the audio wasn't very good and the slides didn't show. So I'm going to give this again. And just to recap on what we did last week and what the concept of this is, I'm trying to convey basic science and cardio and physiology around common pediatric problems, the sorts of things that you would face in the part one examination, but also the integration of basic sciences and clinical medicine is also comes up in the master's exams and in the diploma of child health. So uh, the last week we talked about respiratory physiology and basic sciences, and we started to get onto cardiovascular physiology. We talked about the causes of heart failure, the anatomical and physiological causes of heart failure, and we'd also talked about the different sort of classification and causes of shock. Today we're going to do some more cardiovascular physiology, and we'll see where we get to. So the first question is, explain the cardiovascular physiology behind persistent pulmonary hypertension of the newborn. And to understand this, there's a need to understand the cardiovascular physiology of the fetus and in utero life. And so in utero, remember the circulations operate in parallel. They don't operate in series as the circulations in life do. In ex utero life, in life after birth, the circulations function in series. That is, the blood uh, comes into the left atrium from the pulmonary veins, passes through the mitral valve into the left ventricle, out the aorta, and around systemically around the body, and then back to the inferior or superior vena cava, the veins into the vena cava, and then into the right atrium, through the tricuspid valve, into the right ventricle, and then out the pulmonary artery, and then back through the lungs, oxygenated, and then back to the pulmonary veins. That's a circulation that occurs in series, one after the other, right after left, left after right, etc. But in utero, the pulmonary and systemic circulations operate in parallel, and that's because there is a patent foramen ovale and there's a large duct. So both the aorta and the pulmonary arteries, when they're developed, they eject blood into the aorta. That is, even the pulmonary artery ejects blood into the aorta, partly because the ductus arteriosus is very large, and then all of that blood goes to the placenta, or most of that blood goes to the placenta, where obviously gas exchange occurs, and that enables from the mother's circulation. So that's to understand what happens with persistent pulmonary hypertension of the newborn and the consequences of that. You need to understand the circulations that occur in utero and then in postnatal life. And at birth, of course, the lungs become the organ of respiration, not the placenta. And that happens because of expansion of the lungs that occurs at the time of birth, the clearance of fetal lung fluid, the amniotic fluid that's accumulated in utero. And because of that, pulmonary vascular resistance drops. Now, in utero, the pulmonary vascular resistance and the systemic vascular resistance are the same. They're the same, and that enables the circulation of blood mostly to the placenta. But when the pulmonary vascular resistance drops, then there's a preferential flow of blood into the pulmonary circulation, and the foramen ovale closes. Now, two things happen. One, pulmonary vascular resistance drops, but also systemic vascular resistance increases after birth. And it increases partly because of a catecholamine surge, the stress response of birth, that leads to increased systemic vascular resistance or vasoconstriction. But also the cold external environment also leads to vasoconstriction. So therefore, the SVR increases, the PVR decreases. There's a gradient between the two. Therefore, the foramen ovale closes. The hyperoxic environment, the relative hyperoxic environment of life after birth, leads to a massive drop in prostaglandin secretion, and that leads to the duct closing. Now remember, prostaglandins are mostly vasodilatory, and in the absence of prostaglandins, then the ductus arteriosus usually closes. So those mechanisms by which blood flows right to left in utero life, which is a normal thing, are shut down in after birth, in the hours, moments to hours, or even days after birth, depending on when the duct closes. So that's what happens, and that's normal physiology. But sometimes persistent high pulmonary vascular resistance can occur. And if high pulmonary vascular resistance occurs, then the baby will have pulmonary hypertension in the newborn. So that's the persistent pulmonary hypertension in the newborn. And persistently high PVR can occur if those things don't happen. Like if there's not a hyperoxic environment, but instead there's a hypoxic environment, then there'll be excessive vasoconstriction, and also in the pulmonary circulation, but also because of the lack of adequacy of the partial pressure of oxygen within the systemic circulation, then prostaglandin levels stay high and the duct remains open. So two things happen. The pulmonary vascular resistance increases because of hypoxia. Hypoxia leads to pulmonary vascular resistance, but it also doesn't enable the hyperoxic environment, the adequate oxygen levels to reduce prostaglandin secretion and therefore close the duct. So the duct stays open, PVR stays high, you get right to left shunting through the patent ductus arteriosus. There are some other, so that's the typical persistent pulmonary hypertension of the newborn, or that occurs in a baby who's had perinatal asphyxia. And that can lead to pulmonary hypertension. You'd think that, well, because the circulations were functioning well in utero life, why wouldn't they function adequately ex utero? Well, one, the oxygen level is not high enough. Two, if the pulmonary vascular resistance is very high, then the right heart dilates and you get right heart failure. If the PVR is high, then the right heart will fail. And if the right heart fails, then the interventricular septum is pushed across to the left. There's inadequate filling of the left ventricle, and therefore inadequate stroke volume and inadequate cardiac output going systemically. So that's part of the reason, and the large amount of shunting across the duct, and because of the foramen ovale doesn't close, it still shunts right to left in PPHN. Then deoxygenated blood will go systemically, and the baby will be very blue. There are some other conditions besides perinatal asphyxia that can lead to PPHN, and they are, for example, anything that increases pulmonary vascular resistance in the lungs. So if a baby's born with severe group B streptococcal pneumonia, for example, they've got severe consolidation in the lung, that will increase PVR generally and may lead to PPHN. It can lead to right heart failure. If the baby's got severe acidosis for whatever reason, but that's typically from perinatal asphyxia, or if they've got extreme pain, if a baby has a exaggerated stress response in after birth, then the pulmonary vascular resistance will rise as well. And then there's some structural reasons for underdevelopment of the circulation, such as congenital diaphragmatic hernia, or a hypoplastic lung, or cystic malformation of the lung, or a condition called alveolar capillary dysplasia, where the alveoli and the capillaries are not aligned as they should be in all of the lung or in most of the lung, and that can lead to severe hypoxia. So those babies also have severe PPHN. But obviously congenital diaphragmatic hernia is a more common condition that can lead to severe PPHN, and that does it for two reasons. One, you've got the diaphragm, breach in the diaphragm, and the stomach or the bowel or other intra-abdominal organs in the chest. that's part of it, and that reduces space within the lung for the lung to expand. It increases pulmonary vascular resistance just because it takes up space. But also congenital diaphragmatic hernia is associated with hypoplasia of the pulmonary vascular tree. The pulmonary vasculature is underdeveloped, and so some babies are when they're born, if their diaphragmatic hernia is relatively small, they can have enough lung tissue to survive, and their PVR won't be that high. And some babies are born with large diaphragmatic hernias where there's not enough lung tissue to survive, and the PVR will remain high. In fact, even in babies who have a congenital diaphragmatic hernia where where they've got enough lung tissue to survive, they still have high PVR, often for many weeks, up to 6 weeks or so. So they typically have a form of PPHN secondary to their diaphragmatic hernia. So that's the cardiovascular physiology behind PPHN and normal cardiovascular physiology. And I guess you can see how, if you understand the normal physiology and anatomy, then it can help you understand where things go wrong. Right. The second question, again, it's sort of come up in some of the exams over the years. This question about renal artery stenosis, again, not such a common problem in pediatrics, although in children who've got severe hypertension, we should always consider, do they have congenital renal artery stenosis? But it certainly does cause, it's one of the differential diagnoses of essential hypertension or a severe hypertension or a hypertensive encephalopathy. And so it's the reason to understand the cardiovascular physiology behind renal artery stenosis. It helps us understand about renal blood flow, and it helps us understand about the response of the kidneys to poor renal blood flow. And firstly, I should put this on full screen. Firstly, there's when there's obstruction to renal blood flow because of like a so-called mid-aortic syndrome, if there's a coarctation or there's some obstruction to renal blood flow, then there'll be reduced blood flow to the kidneys. And anything that causes reduced blood flow to the kidneys activates the renin, angiotensin, aldosterone system. And that leads, there's renin is produced by the kidneys. It's converted to angiotensin 1 and then angiotensin 2. And angiotensin 2 is the most potent vasoconstrictor in the body. So that leads to systemic vasoconstriction. The blood pressure increases. And also it increases the production of aldosterone. Aldosterone leads to sodium and water retention and therefore hypertension. And so that increased circulating blood volume, the intense vasoconstriction that occurs from angiotensin 2 leads to severe and often intractable hypertension in children or adults who've got renal artery stenosis. And that has an effect. This is often also asked in Part 1 examinations. What's the effect of systemic hypertension on the heart? And the concept being that anything that puts a pressure load on the heart will lead to myocardial hypertrophy. It makes the heart thicker. Anything that increases the volume load on the heart will lead to myocardial dilatation, the dilatation of the ventricles or the chambers that are so affected. And so you can think about the different conditions that might lead to an increased pressure load on the heart. So any stenosis of a valve will lead to a pressure load on that chamber. So aortic stenosis leads to a severe pressure load on the left ventricle. Mitral stenosis leads to a pressure load on the left atrium. And so therefore the response to that is muscle hypertrophy. It's just like if you put a pressure load in any skeletal muscle, over time that will lead to muscle hypertrophy, exercise, etc. But systemic hypertension does the same thing. It leads to remodeling of the ventricular muscle with myocardial hypertrophy. So that's the if you were to try to explain the cardiovascular physiology and the effects of renal artery stenosis, then that's what you could say. Okay, right. So this also is a common question that's asked in examinations. That is the cardiovascular physiology behind a large VSD. And the reason to ask it, the reason to need to know this question is partly that it's useful to understand what the effect of left to right shunts are. And the left to right shunts that can occur are large ventricular septal defects, atrial septal defects, atrioventricular septal defects, patent ductus arteriosus. That's typically in the normal course of events, it's a left to right shunt. Of course, if you've got PPHN, it's a right to left shunt. As with all of these defects in the heart that lead to mostly a left to right shunt, if there's severe pulmonary hypertension, the blood can flow the other way. I'll explain that in a bit, but mostly a VSD, ventricular septal defect, is a left to right shunt, of course, and the blood flows from the left ventricle to the right ventricle. And the reason why that causes to try to explain the clinical features that you see in children who've got a ventricular septal defect, then to understand this, that when there's a large left to right shunt, then the blood flows from the left ventricle to the right ventricle, and then it goes through the pulmonary artery, then through the pulmonary circulation, and then back to the left atrium, through the pulmonary veins, into the left atrium, and then through the mitral valve, and then into the left ventricle. And then some of it goes back again across the intraventricular septum through the ventricular septal defect, and some of it goes then antegrade, that is through the aorta, and goes systemically the way it should go. But you've got a lot of blood coming back to the left ventricle that, instead of going out the aorta where it should go, it actually goes across to the right ventricle and then circulates again. And the situation is often that there's a concept called the QPQS ratio, not ration, but ratio. And what that means is the ratio of the flow in the pulmonary circulation to the ratio of the flow in the systemic circulation. And normally that should be 1-to-1. Not in a circulation that runs in series, like we have in postnatal life, a circulation that runs in series, then it should be 1-to-1, because it's the same blood is going through the left side of the heart, and it's going out the aorta and back to the right side through the veins, and then out the right side of the heart through the lungs, and then back to the left side. It's the same blood. So the ratio of flow in a normal person is 1-to-1. But when a child's got a ventricular septal defect, it might be 1.5-to-1. That is 1.5 times as much flow goes through the pulmonary circulation as what goes through the systemic circulation. Or if it's a large shunt, it might be 2-to-1. That is twice as much blood goes through the pulmonary circulation through the ventricular septal defect, and then back and circulating again. Or it might be 3-to-1. A very large shunt might give you a 3-to-1 shunt. And what that does is the increased pulmonary blood flow leads to two things. One, it leads to pulmonary hypertension. And anything that increases the blood flow substantially like this will lead to pulmonary hypertension. Firstly, that pulmonary hypertension is reactive. That is, the increased blood flow per se will give you a pulmonary hypertension, but then the pulmonary vasculature reacts to the increased blood flow. It becomes reactive, and you get pulmonary vasoconstriction, which increases the pulmonary vascular resistance and increases the pulmonary blood pressure. Later on, though, if that persists for weeks and months on end, then you get remodeling of the pulmonary vasculature that leads to, like this remodeling we talked about of the ventricular myocardium. Under a pressure load, you get hypertrophy, and the pulmonary vasculature is made up of the intima and the media. Intima being the endothelial surface, and the media being the sort of smooth muscle underneath. And it's you get intimal thickening, and you get medial hypertrophy, medial being the smooth muscle hypertrophy, and that can lead to fixed pulmonary hypertension. And if a child has that, usually some years after having a large VSD, then they will get Eisenmenger syndrome. That is, their shunt will no longer be left to right, but because of the high pulmonary vascular resistance and the fixed pulmonary hypertension, they will often shunt right to left, and so they'll develop cyanotic heart disease. It's a condition of great significance, because if a child gets Eisenmenger syndrome or fixed pulmonary hypertension, then fixing their ventricular septal defect won't solve their problem. In fact, it'll lead usually to right heart failure. We rarely see Eisenmenger syndrome these days. Usually ventricular septal defects are picked up much earlier, of course, and the babies have an operation, or if it's a small VSD, then they're not going to develop severe pulmonary hypertension usually anyway, or the VSD will close spontaneously. But if babies have moderate to large ventricular septal defects, or even moderate to large atrial septal defects, and they're not addressed, then they will inevitably develop fixed pulmonary hypertension and may develop Eisenmenger syndrome. So that's in time. That's the effect of ventricular septal defect on the pulmonary blood flow and on pulmonary vascular resistance and the pulmonary artery pressure. But the immediate manifestations of the increased pulmonary blood flow is more alveolar congestion. And so when we see a baby with ventricular septal defect, well, they've typically got the clinical signs of fast breathing, especially with feeding, and they may sweat, and they'll be tachycardic and tachypneic, and they'll have some respiratory distress, and their lungs will sound a bit crackly, and there'll be some congestion on their lungs. And that's all because of pulmonary blood flow. If you've got a QPQS of 1.5 or 2 to 1, then your lungs will become wet and poorly compliant. That means they'll just become stiffer. When lungs become wet, they just become stiffer, and that leads to dyspnea with feeding. Typically, feeding is often the most exercise a baby has, isn't it? They have to suck on the breast, and that actually requires quite a bit of energy to do so, and they often become tachypneic because they're having to use a lot of energy to keep breathing adequately when they've got such congested lungs. And so that's why babies with ventricular septal defects present with tachypnea and sweating on feeding, and poor feeding and failure to thrive because they're not getting adequate breast milk, etc., and almost always tachycardia. That's the cardiovascular physiology behind a large ventricular septal defect. And again, it's something that is often asked in exams. Right. Now, next question. To explain the cardiovascular pathophysiology behind acute rheumatic fever and rheumatic heart disease. And I guess to understand acute rheumatic fever and rheumatic heart disease, you need to understand two things. One is the immunopathology, and two is the cardiovascular pathology or pathophysiology. And so this is a good question, again, to ask, because it helps us understand immunopathology and also cardiovascular pathophysiology. So I guess to understand the first part, the immunopathology, well, firstly, following group E streptococcal infections, remember group E streptococcus can cause many things, but it can cause two main conditions. One is pharyngitis, or a streptococcal sore throat, and the other one is pyoderma, or a skin infection, and that can be, for example, infected scabies can often be infected with scabies, or any breach in the skin can often be infected with group A streptococcus. It's often a commensal on skin, but also it can cause an infection called pyoderma or impetigo. Impetigo being often called school sores, and that's usually an infection around the mouth. So group A strep infection, a bacterial infection that causes these infections and many others, of course, it has, all bacteria have certain antigens, and antigens generate an antibody response, and they also generate usually a T cell response. Now, remember, there's two parts to the immune system, or well, many parts, but there's two parts to the there's to lymphocytes. There are two types of lymphocytes. There are T cells and B cells, and the B cells produce antibodies, right? And the T cells usually stimulate phagocytosis and other things. There's two types of, well, several types of T cells. You'll be familiar with CD4 cells and CD8 cells. CD4 cells being T helper cells and CD8 cells being T killer cells. It's the CD4 cells and B lymphocyte activation that is involved in the genesis of rheumatic heart disease and acute rheumatic fever. And the bacterial antigens of group A streptococcus stimulate T cells, especially T helper cells, and they stimulate B lymphocytes to produce IgG, immunoglobulin G, and IgM, immunoglobulin M, and they're antibodies against the group A streptococcal antigens, but they also happen to cross-react. They do two things. One, they combine with the antibodies and can produce an antigen-antibody complex or a CD4 T cell antigen complex, but they also can cross-react with certain of the tissues in the body. Now, most antibodies that are produced don't do that, but antibodies and cellular immunity to group A streptococcus does that. I should explain the two types of immunity. One is called cellular immunity, and that relates to it's generated by cells, so typically T cells, and the other one is humoral immunity, which is generated by antibodies. So when you hear those terms, cellular and humoral immunity, they're focusing on immunity related to lymphocytes, typically. Now, usually, as I said, when we produce antibodies to certain bacteria or certain viruses, they don't cross-react too much with our tissues in the body, but for group A streptococcus, they do. And both the antibodies and the T cells that are produced in response to group A strep affect cardiomyocytes and heart valves particularly, and they affect it in terms of antigen-antibody complex deposition, T cell infiltration, and the formation of these things called Aschoff nodules. They're just granulomas, which are inflammatory masses of inflammatory cells within the tissues. And you can see that on histopathology of a child who's got rheumatic heart disease. If they've got rheumatic carditis, then they will have Aschoff bodies or T cell inflammation within the lymphocyte inflammation within the heart and muscle tissue, and also in the heart valves. The infiltration can cause pericarditis, which is an inflammation of the pericardium, of course, myocarditis, the inflammation of the heart and muscle, and valvitis, which you know about, which is an inflammation of the valves. And when it affects the valves, it can lead to, well, it does lead to valvular inflammation and fibrosis and thickening. Now, the valves are usually quite compliant valves. They're usually quite soft. They open and close dozens and dozens of times per minute, don't they, all throughout life. But if they become thick, then they're more stiff, they're harder to open. They may stay open and therefore be regurgitant, or they may be stiff and closed and therefore be stenotic. And so when they don't, and the consequence of that is if they're regurgitant, then blood will flow retrogradely back. Blood will flow retrogradely on systole, for example, through the mitral valve. If there's mitral regurgitation, then blood's flowing back from the left ventricle to the left atrium because the valve doesn't close properly because it's too stiff. Or if the valve is stiff and doesn't open properly, then there'll be a stenotic element to the valve. And for many of these valves with acute rheumatic fever and rheumatic heart disease, there's both stenosis and regurgitation. That is, it's narrow, the aperture is narrower, but still blood can flow up because it doesn't close properly. And that leads to the manifestations of that we see with the pressure or the volume load on the heart, depending on whether the valve is very stiff or the valve is very leaky. If it's a very leaky valve, it produces a volume load on the ventricle. If it's a very stiff valve, then and it's stenotic, then it produces a pressure load on the preceding cardiac chamber. I hope that makes sense. If for example, you've got a mitral stenosis, it's producing a pressure load on the left atrium. If you've got mitral regurgitation, that's producing a volume load on the left ventricle. Right? Yeah, you might have to think that through, but when you've got a regurgitant valve, then some of the blood that's expelled at systole from the left ventricle will go out the aorta, and some of it will go back into the left atrium. And so therefore that's extra volume the heart has to pump to get the same amount of systemic blood flow. And that's why it's a volume load. And that's why when you've got a regurgitant mitral valve, then, or an aortic valve, then you just get progressive dilatation of the left ventricle. On the other hand, if you've got a stenotic mitral valve, then that doesn't produce a volume load on the heart. In fact, less blood flow is flowing from the left atrium to the left ventricle, but it produces a very substantial pressure load on the left atrium, because that's the preceding chamber that's trying to pump blood into the left ventricle. See, just think that through. The mitral and the aortic valve in rheumatic heart disease, as you know, are most commonly affected, and that leads to heart failure. But I've tried to explain the mechanisms of that heart failure, sometimes because of the stasis of flow, because of the inadequate blood flow that's coming through the mitral valve, typically, then because of stasis of flow, or because there's disruption of normal laminar flow within the left atrium or the left ventricle, then clots can occur, and that can lead to clots. Clots can be on the valves themselves or in the atrium, and from that, of course, it's not very far until strokes can occur, and this is especially a problem if you've got stasis of flow and there's atrial fibrillation. And many children with rheumatic heart disease have atrial fibrillation, or they may go at some stage into atrial fibrillation because of either myocarditis, as in inflammatory infiltrate within the atrium itself that can lead to atrial fibrillation. Remember the sinoatrial nodes in the right atrium and the AV nodes in the interventricular septum, or the intraatrial septum, that endocardial cushion between the two, and that when that happens, that can lead to atrial fibrillation. And if a patient goes into atrial fibrillation and they've got stasis of flow, then there's going to be very limited, like blood won't flow smoothly, and therefore blood will clot within the typically within the left atrium. And as I said, it's not that far from a clot. It doesn't have to be a large clot, even a relatively small clot, if it gets into the left ventricle and then gets through out the aorta, then it's quite likely to go to the brain and lead to a stroke, or go to some other systemic organ like the liver or the spleen or the kidneys and lead to infarcts, or the bowel and lead to multi-infarcts. And so we've seen children with acute rheumatic fever who have clots in their atrium or in their ventricle that have all of these multi-ischemia, multi-emboli phenomenon. Right. As I said, the inflammation of rheumatic fever can occur on the valves, or it can occur in the heart muscle, and that can lead to conduction defects. So if there's a conduction defect, remember the two major aspects of conduction are the sinoatrial node and the AV node, and the two common ECG changes of acute rheumatic fever or rheumatic heart disease are a prolonged PR interval and the PR interval goes from the sinoatrial node to the AV node, and anything that lengthens the length of conduction between the sinoatrial node and the AV node, if there's a delay in that conduction, then there'll be a prolonged PR interval. And what the things that can delay conduction between the sinoatrial node and the AV node would be any inflammation, where the conduction fibers might have to go follow a different route than the normal. The normal route of conduction is usually the quickest way, and if there's any inflammation or any fibrosis along that conduction pathway, then the SA node will either be completely blocked, so you have a complete heart block, or it'll find its way around through some other conduction pathway, so therefore the PR interval will be long. That's the mechanism for a prolonged PR interval, and that's why it's relatively common in children who've got acute rheumatic fever. If they've got a carditis, then it's quite common. The other feature is atrial fibrillation, and when there is stretch on the left atrium, then that increases the risk of atrial fibrillation. Also, atrial fibrillation can occur if there's heart block and there's some other aberrant conduction pathway within the atrium that leads to a firing of the conduction, initiation of the conduction that results in atrial fibrillation. So anything that causes pathology of the left and right atrium, particularly the right atrium, well, both atria, can lead to atrial fibrillation. And this can just be because of the antibody complexes or the inflammation that exists within that from acute rheumatic fever. The antibodies, of course, that can also, to group A strep, can also cause other affect other organs, and the antibody complexes that get deposited in joints cause arthritis, or the inflammation of the joints that occurs because of the cross-reactivity of antibodies and T cells to group A strep and joint tissue, synovial tissue, can lead to arthritis. And the antibodies also bind to the basal ganglia, and you get inflammation within the basal ganglia causing chorea. That's the basis for Sydenham's chorea. So that's the immunopathology of acute rheumatic fever and rheumatic heart disease, and it's certainly worth knowing that. One of the most common arrhythmias in children is supraventricular tachycardia, and we've talked a bit about the other forms of arrhythmia, atrial fibrillation, etc., prolonged PR interval that occur in acute rheumatic fever. But supraventricular tachycardia is usually, it can occur because of some other secondary pathology, but it usually occurs because of a congenital abnormality, an abnormal focus of conduction within the atrium, an abnormal focus of stimulation of the cardiac conduction. So instead of it being in the from the sinoatrial node to the AV node, then there's some other focus within the atrium that leads to the and it's firing at a more rapid rate than the sinoatrial node. Normally, as I said, the conduction goes sinoatrial node to the AV node, but if you've got an aberrant focus within the atrium, or again, this is a bit of a difficult concept, but a condition called a reentrant tachycardia. Most SVTs are actually reentrant tachycardia, which means that the cardiac impulse goes from the atria to the ventricle, but then there's a retrograde conduction pathway that goes rapidly back to the atrium, and so there's a constant circular pathway between the atrium and the ventricle, and that's why the rate is so high. This reentrant tachycardia is probably the most common cause of supraventricular tachycardia, but there are other causes as well that relate to aberrant foci. Aberrant means unusual or not normal, not abnormal focus within the atrium for the conduction pathway. The causes mostly congenital, as I said, sometimes inflammatory, sometimes myocarditis related to virus, enterovirus, or some other virus, and sometimes rheumatic heart disease can cause SVT, supraventricular tachycardia as well. There are some exacerbating factors, and as I said, anything that causes atrial stretch, anything that leads to a stretch on the atrium can lead to atrial fibrillation, or it can lead to SVT, because it's really just it's applying abnormal forces within the myocardium, and therefore that has an effect on the conduction system as well. There are some other exacerbating factors. So mostly children with SVT who have a propensity to SVT don't have SVT. They're in sinus rhythm. But if they get a fever, if they get extra stress, if they have electrolyte imbalances like hypokalemia or hypomagnesemia or severe acidosis, that can lower the threshold for SVT. One of the most common antecedent events, or the precipitants for SVT, is a stress response. And so any situation where there's a catecholamine surge, a surge of adrenaline within the body, can lead to SVT in a susceptible person. And that's the reason why I mention this, is because typically the scenario will be SVTs occurred spontaneously, or a child's collapsed on the soccer field or playing rugby or something. They've collapsed for no good reason. They weren't hit or anything. They just collapsed. And that may be because they've had an arrhythmia. Could be SVT, could be some other form of catecholamine stimulated arrhythmia, but anything that leads to that. So, for example, in those children, like, adrenaline's not good for you. It will stimulate worsening, a faster heart rate, more propensity to SVT. And so actually the treatment is to lower the heart rate, of course, isn't it? It's with beta blockers, typically beta blockers, or adenosine or digoxin, whatever. SVT produces a heart rate that's always above 200. It's usually about 250. And the reason why that leads to typically infants present with extreme pallor, and they're markedly tachycardic, heart rate of 200 or 250, and they've got cold peripheries and very poor volume pulses. And the reason for that is because a heart rate that's that fast, anything above about 160 in children, leads to reduced stroke volume. And it does that because the ventricles don't fill adequately, and the heart's going too fast to actually enable it to fill. So the ventricles don't fill, therefore the stroke volume is low, therefore it's a low cardiac output state. And that's the typical presentation of children who've got supraventricular tachycardia. Either it's an infant who just presents apparently in shock, with cold peripheries, looking very pale, poor volume pulses, low blood pressure, heart rate of 200 to 250, or it's an older child who has a sudden collapse while doing something, playing sports or doing something that involves a sort of adrenaline or catecholamine surge, or it's a child who has a intercurrent infection and they've got a fever, or they've got high levels of catecholamines, and they can go into SVT. So a child who's got a propensity to supraventricular tachycardia can be prone to all of those types of presentations. Okay. Now, this last question, we talked a bit about the different sorts of heart failure in the previous lecture, but I wanted to try to explain the physiology and pharmacological basis for the treatment of heart failure. And so we'll just go through that now. That, again, a fairly common question to be asked. And there's two sorts of heart failure. I put these perhaps round the wrong way, but the type of heart failure we commonly think about is congestive heart failure. In fact, often people use the word congestive heart failure, and it might be a combination of both, but congestive heart failure means that there's high left ventricular end diastolic pressure. Now, that's a concept that might be hard to grasp, but if the left ventricle is not pumping well, then at the end of diastole, which is when the heart should fill, then the heart may be and be ready for systole, ready for pumping, then the pressure inside the ventricle, because of the myocardium isn't pumping, the myocardium isn't strong, as strong as it should be, then there'll be high left ventricular end diastolic pressure. That is, the pressure inside the ventricle will be transmitted then back typically to the atrium and then to the pulmonary veins. And when that occurs, there's increased left atrial pressure. So the left ventricular pressure will be high, the left atrial pressure will be high. That leads to pulmonary venous hypertension and then pulmonary and alveolar congestion. If you follow the pathway of pressure back, then anything that increases pressure will lead to edema or congestion. So that's the basis for congestive heart failure, and that can occur in any situation where the left ventricle is not pumping well. It could be ischemic in adults, for example. It could be a hypertrophic cardiomyopathy in children. It could be myocarditis. It could be acute rheumatic fever. They will all be associated with congestive heart failure and a high left ventricular end diastolic pressure. If a child's got heart failure from a ventricular septal defect, for example, then they also will have a high left ventricular end diastolic pressure. That just means the pressure in their left ventricle is high, therefore their left atrial pressure is high, and that will cause a backflow of pressure into the lungs and pulmonary congestion. That's the common, I suppose, way we conceptualize heart failure. That is congestive heart failure, and that's the reason for the basis for much of the pharmacological treatment of heart failure is to deal with congestive heart failure. For example, giving diuretics reduces preload on the heart, so it reduces the amount of blood flow that's backing up. There's reduced blood flow in the venous circulation when you're on diuretics, and therefore it reduces the pressure on the heart and allows the heart to function on a better Starling curve. Remember, the Starling curve suggests that if the heart dilates a little bit, then that increases the actin and myosin smooth muscle fibers ability to contract, so therefore that will increase contractility. But if the actin and myosin fibers are too far apart, then the contractility will be reduced. And so anything that increases left ventricular end diastolic volume or pressure a little bit can be good, but a lot can be excessive, and that then the Starling curve is means the heart will go into failure because there's too much stretch on the myocardium. So that's congestive heart failure. Forward failure is the other type of heart failure, and both things happen at the same time, congestive and forward heart failure. And when there's impaired myocardial contractility, that is the left ventricle is not contracting well, then there'll be a low ejection fraction, and that is a greater proportion of blood won't be pumped out of the heart. More of it will just stay within the ventricle because the heart's not pumping enough blood. The left ventricle can't pump all the blood. Normally, the ejection fraction is very substantial. It pumps most of the blood out of the left ventricle that fills it. But if the ejection fraction is very low, then that means the stroke volume will be low, and there'll be a low cardiac output state. And what the reason to understand what a low cardiac output state is because of the consequences lead to heart failure. And when there's a low cardiac output state, there's an activation of all of these adaptive mechanisms that become maladaptive. So firstly, there's an activation of the catecholamine system, and you get vasoconstriction. And so when there's a low output state, then the blood pressure remains okay because of vasoconstriction, because the low output state stimulates catecholamines, adrenaline and noradrenaline to cause vasoconstriction. It also stimulates the renin-angiotensin and aldosterone system, and that of course leads to again intense vasoconstriction and retention of water. And to begin with, that's adaptive. That's helpful to the to the person who's in heart failure. There's also, because of low output, there's a stimulation of antidiuretic hormone, and that also, it leads to restoration of the cardiac output by tachycardia and vasoconstriction and expansion of the extracellular fluid volume. This Frank-Starling mechanism leads to that. That is, if there's increased blood volume, tachycardia and vasoconstriction, then the heart will function just a bit better. But that's only to a point. And that point is passed rather early. And when when that's passed, these mechanisms lead to heart failure, as in the heart dilates up too much because there's too much fluid collection, and the vasoconstriction puts a pressure load on the heart that is the afterload, an afterload load on the heart, etc. And these maladaptive consequences increase the afterload from increased systemic vascular resistance on a failing heart, and the increased catecholamine surge that you get when you've got low output state, that can exacerbate coronary ischemia, or in an adult who's got coronary artery disease, but it can also cause hypertrophy. Remember, anything that causes hypertension or a pressure load on the heart, any increased afterload will cause myocardial hypertrophy, and that really again exacerbates the release of catecholamines and heart failure. So it's these consequences of low output state that are initially and transiently adaptive that lead to heart failure, and also congestion from high left ventricular end diastolic pressure and backflow of blood that leads to heart failure. So forward failure and backward failure, if you like, and that's the pathophysiological basis of heart failure. And then what do we do about it? Well, that's the basis for these the pharmacological management. Firstly, the oldest mechanisms were to reduce preload, and so giving diuretics, especially furosemide or spironolactone, they reduce preload. They'll reduce the pulmonary congestion. They reduce intravascular water. They reduce edema, etc., and that will reduce preload. So therefore, the heart will function much better. There's also agents, of course, that reduce afterload. Lots of vasodilators, sodium nitroprusside, glycerol trinitrate. The common ones used these days are angiotensin-converting enzyme inhibitors, of course, like captopril and enalapril, and calcium channel blockers like nifedipine. They reduce afterload on the heart, and that's highly effective if there's a low output state, not where there's and there's hypertension. If the child's got hypertension or a normal blood pressure, then those agents can generally be used, but not if there's hypotension, because they'll obviously reduce blood pressure. They vasodilate, and they block those maladaptive mechanisms where you've got high angiotensin and you've got high renin and aldosterone levels. There's also, so reduce preload, reduce afterload, and thirdly, increase contractility. We don't have too many drugs that can increase contractility these days, or increase contractility effectively. Digoxin has a very weak effect on increasing contractility, and it's really only useful, digoxin would only be really useful when you've got atrial fibrillation and fast atrial fibrillation, because it slows the heart rate. It has a little effect on improving myocardial function, so it can be worth using. But for example, in children who've got acute rheumatic fever, it's only really worth using if patients got atrial fibrillation. Other than that, it probably causes, there's some side effects of digoxin, probably causes more harm than good. In other situations, occasionally we'll use digoxin, but usually not. In atrial fibrillation, it's very effective. Other agents that improve contractility, adrenaline, obviously acutely, typically adrenaline will increase contractility, but not for sort of chronic use in heart failure. There's some other medications, milrinone somewhat increases contractility, and also helps the heart relax a bit more and take a bit more blood volume in, and so therefore feel a bit better and therefore empty a bit better. So there's some other drugs that work. There are some medications that slow the heart rate to ensure adequate ventricular filling, and digoxin being one of those. If a child's got atrial fibrillation, but also in heart failure, it's sometimes advantageous to slow the heart rate to a level that's not too slow, and even at the upper limit of the normal range, and that can reduce the effects of adrenaline and other catecholamines on myocyte function, and that can be beneficial to a point. And so some beta blockers, especially a beta blocker called carvedilol, that is shown to prolong survival in adults who've got heart failure, and most adults with heart failure on carvedilol or something similar. There's some evidence in adolescents that also it can be effective, who've got cardiomyopathy or myocarditis, it can be effective. So it's worth thinking about. But I think the main, if you were to answer this question, to address heart failure, we have to reduce preload, we have to reduce afterload, and we can do what we can to increase contractility. But then also we need to think about what's precipitated this child's heart failure. Is it that they've got an underlying arrhythmia? Have they progressively got worsening anemia? Have they got an episode of acute rheumatic fever, and they've got atrial fibrillation, or they've got new myocardial inflammation? So have they been non-compliant, obviously, with their medications? So have they got an intercurrent infection that led to fever? It increased the work that the heart had to do, so therefore it went into heart failure. So think about the underlying cause of the child's heart failure, as well as the pharmacological things to do about it: reducing preload, reducing afterload, increasing contractility, etc. Okay. Well, I think we'll stop there, and so we've covered in these two lectures, we've covered respiratory physiology, and we've covered cardiovascular physiology, and I hope that's been useful to you. In the next lecture, we'll cover neurology and neurophysiology, and the how to explain common pediatric neurological problems in terms of physiology and anatomy. I'm going to stop sharing there and stop recording.